you are welcome to keep your video on or off, whatever is the most comfortable for you. We do ask that everybody stay on mute until the question and answer portion, but you're welcome to share questions in the chat or make a note and make a note of it and let us know your question at the end of the hour. This will be recorded, so just so you're all aware. Just a brief word about the Leaders in Global Health seminar series. This series is for the purpose of bringing innovators who have impacted global health through disruptive technologies, novel educational models, and social entrepreneurship. And today we're excited to have Dr. Acharya from Johns Hopkins as our guest. And so now Dr. Ramanujam, our director, will introduce our speaker.
Thanks, Antonia. So it's great to introduce Dr. Acharya, who is an assistant professor of biomedical engineering at Johns Hopkins. And he has essentially founded this incredible graduate innovation program. I just found out it's a year. I thought it was 2 years, where it's called the Johns Hopkins Center for Biomedical Innovation and Design, or CBID. And basically what he does is guide graduate students on the process of global medical technology innovation. And the idea is to develop frugal technologies for public health interventions worldwide. And he has also been involved in the invention and early stage development of several diagnostic and therapeutic technologies, specifically on neonatal and maternal mortality. Dr. Acharya has a number of awards. I'm just going to name a few. The Olympus Emerging Educational Leader Award, the National Collegiate Inventors and Innovator Alliance. And so it's clear that he is a recognized educator and innovator. And I'm really excited, Dr. Acharya, for your seminar today.
Thank you, Dr. Ramanujam. Great pleasure and honor to be here. Thank you for the kind words. So I'll just get on with it. I'm just so excited to speak to you all and share some of our stories, our adventures. I'm Shomo Acharya. I run a program in medical device innovation, tinkering, entrepreneurship, and have a lot of fun doing it with the really bright students. So let me give you a little bit about our program. So our center, which is both within the School of Medicine and the School of Engineering, we kind of have a dual mission. So training of our students, that's the product of the program, but also we're equally serious about the outcomes of the projects that they work on. So the creation and early stage development of healthcare solutions that have a transformational impact on human health around the world. So we're not just about students working on projects as a learning experience, but we're really serious about the projects themselves. So a lot of effort, energy goes into those partnerships and for the runway beyond the student's tenure. And we'll just share some examples of those today. Just a snapshot of outcomes from our projects. We've had about 15 or now actually 18 startups from our program, several of which are now post-FDA. Collectively, students have raised a lot of venture money. There's 2 or 3 companies that have exited. And the main product, of course, is there's about 200 alumni now of our program over the last 10 years. So any of you undergrads looking for grad school with a slightly different flavor, which is more focused on innovation, clinical or public health needs-driven innovation, be it in the global health space or in the US marketplace, check us out. All right, so my talk is going to be mostly or almost exclusively about our technologies that our students have worked on global health and what that journey looked like and some of the oops moments during that journey. So this is one of my favorite pictures because global health or any healthcare innovation really should begin with understanding and listening. And that's what these four of my grad students are doing here. This is a nurse midwife up in a fairly remote district in Nepal. And therefore, one of my favorite pictures. So that's what they're truly doing. It starts with understanding. Now, understanding the technology, the context is not just about technology, right? It's about understanding the infrastructure constraints, the lack of awareness of health-seeking behavior, oftentimes, lack of resources, resource constraints, and how people work around those. This is one of my favorite trips. This is up in Jumla, a remote district in Nepal-China border. And we were visiting this subsidiary health center. And these are female community health volunteers, several of whom did not have a school education, several of whom, and the highest educated person, I think, was elementary school educated. But I was so impressed by how intelligent, motivated, and driven they were. These young ladies were actually being trained in neonatal resuscitation, because they're the last mile bridge between a child, a neonate that's born up in the mountains, not in a facility, in a home, and them being able to survive birth asphyxia. So every time I've had these chances to interact, I also look for bright spots. So that's the point I wanted to make, that don't just look for constraints and problems, but also look for what works, the human spirit, enthusiasm, and how people make the best of the circumstances. And as innovators, how can we help facilitate that better? So again, another picture of 3 of my students demonstrating an early concept of something that they developed and interacting with the community health workers there in a subsidiary health center in Nepal. So overall, if I zoom out, solutions, really, some of the principles we try to follow is that we would like to work on conditions that have some of the highest burden of mortality and morbidity, targeting low and middle income countries, especially the last mile. Solutions do need to be evidence-based, and they have to have a potential for high impact. So we think about scale up and impact from day 0, right? And they have to be frugal, highly affordable, or cost effective. Sometimes there could be more cost involved upfront, but in the long run, they have to be cost effective. And obviously, they have to be appropriately designed with the users and all the stakeholders in mind. So how do you do it? To navigate this, there are so many perspectives to navigate. It's almost like a collage, a jungle, a mishmash, right? You have the physicians, the surgeons, the community health workers, and then you have the primary health center, hospitals, you have the Ministry of Health, the policymaker, the donor, and then of course you have issues with technology, like will this work? Will users love it? Will the core biological principle hold true? Partnerships with major donors, NGOs. So how do you navigate as an innovator? What do you do first? And what do you do second? What do you do last? It turns out all of them. You got to do all of them at once. And therefore, the model that we kind of try to expose our students to philosophically is this iterative or spiral innovation approach, where you do not ignore any of these quadrants, the clinical public health quadrant, the implementation, technical and strategic quadrants, but you do so commensurate with the stage of the project. So this area under the curve kind of represents philosophically the time, effort, money invested. And with each iteration, you gain deeper and deeper understanding of the problem, a higher resolution solution, a more nuanced kind of testing of the various hypotheses, not just the technical biological hypothesis, but the usability, the fundability hypothesis, et cetera, et cetera. And with each iteration, you modify, pivot, kill. And let me share some stories of those modifications and pivots and kills. So here's the one that, this is from a couple of years ago. I'm particularly proud of this one because we persevered. This is about maternal anemia. So anemia is actually a vexing problem that contributes so much to the burden of maternal mortality, contributes to over 100,000 maternal deaths and a huge burden of morbidity, right? And as most of you might be aware, in pregnancy, you get iron supplementation. Every woman should be screened for anemia and the severity of anemia throughout pregnancy to mitigate that, right? The problem is that antenatal coverage is really poor in rural parts of the world, in low middle income countries. And governments have tried, they are trying, donors are trying, like how can we ensure better antenatal coverage? How can we identify those women who maybe have severe anemia and that some intervention could be done, such as more aggressive interventions like a blood transfusion or an intravenous iron, a parenteral iron, etc., for those women who have severe anemia. I have personally seen with my students women in Rajasthan give birth with hemoglobins of 4. I have seen a woman give birth with a hemoglobin of 4. And those of you who know what that is, that's like a zombie walking. How can you even think about that person giving birth? But that's the reality, because these women have never been screened for anemia throughout their life. The first time they interact with the health system is on the day of childbirth. So the existing diagnostic tools, right, lab-based or some of the simplified ones, are actually not appropriate to take out this testing to the doorstep of women, right? So we, a couple of years ago, got an award from USAID, Saving Lives at Birth Grand Challenges. We had proposed a very early stage concept that what if we could develop a non-invasive hemoglobinometer using some intelligent mix of infrared, near-infrared wavelengths of light. If pulse oximetry is possible, why not total hemoglobinometry? In our naivety, we kind of plunged that way. Boy, were we naive, right? And the idea was that, well, most community health workers have a phone. It could not, maybe not a smartphone. They do have dumb phones, most of them. And that phone is a powerful enough computer. It's actually a computer that's more powerful than the computer that landed man on the moon for the first time. So maybe we can, leverage some of its computational power, the fact that it has a display, and develop a really low-cost sensor, and then somehow communicate. Our students had actually developed a way to audio modulate the plethysmogram and send it over the audio jack of a simple phone, so that even non-smartphones could have some data transfer from a smart device. And so this is a cartoon of the conceptual one. This is prototype 1, a non-functional cartoon for communication purposes, and they had built it out that the health worker will see this on the screen. They will see the hemoglobin level, a red, green, yellow, and then it would also be reported to a centralized dashboard, a Google map, if you will, of anemia, so that the health officials at the district level can now follow up with the patient, or with the health worker. So if there's a woman with a hemoglobin of 6 or 7 out in the community, that woman needs to come into the hospital for an urgent blood transfusion if she's in the 3rd trimester, especially of pregnancy, right? Unlikely to survive childbirth. So now you have the ability for the first time for the district health official to call up that community health worker whose cell phone this originated from and say, hey, I noticed you detected someone in your village with a hemoglobin of 7 yesterday. Did you make sure she came to the hospital for a blood transfusion? That's transformation. And we got this feedback so many times. I've spoken with the Ministry of Health in Kenya, in Nepal, in some districts in India, in Rajasthan particularly. And turns out they love this telemedicine component as well, which is, now the health ministry can actually view how their community health programs are doing. But I digress. So that was a very interesting prototype 1. When rubber hits the road and we started building the first functional prototypes, the sensor with like 4 or 5 wavelengths. So this was prototype 1. Prototype number 2, we did a major clinical study, 800, actually more than that. It was close to 1,000 women in antenatal clinics in India and Nepal. No, it's not mentioned, but so in India and Nepal, we collected tons of data, women in antenatal clinics, and our algorithm did not work. It kind of completely fell flat on its face. We had this funding from seed funding from USAID, so relatively high visibility project. And it was kind of disaster in some ways, because some of the NGO partners with whom we had built up this anticipation and excitement that, oh, this is coming, this is pipeline, all set. These Johns Hopkins smart people have it figured out, but we did not have it figured out. So the project it was one of my first learning experiences early on that, temper expectations with your partners. If things can go wrong, they will go wrong. And it's not correct to, build up expectations beyond, even if you're enthusiastic about it. But there was, a silver lining. We kind of figured out why it didn't work, even though it set us back by almost 1.5, 2 years. But it turns out that the sensor design needed to be much more high precision. All the wavelengths of light needed to come out from a single point source, blah, blah, blah. And we worked with a company, Bosch, and they developed the prototype 3 for us. And then we did another clinical study 2.5 years later with about 1,400 pregnant women in clinics in India. And it actually is a functioning device. We published this. It's actually featured on the cover of IEEE Journal of Biomedical and Health Informatics. the very interesting machine learning techniques were used. So instead of trying to brute force develop equations, I threw up my hands and I said, I'm not good at math. Let's just use machine learning. And that's what worked. So, and so this, if you're interested, you can read up this paper. And furthermore, it turns out in the meantime, we discovered that a decimal level precision of what the hemoglobin number is not actually necessary. What you really need for a public health intervention is that, is this a severe anemia? Is this moderate anemia, mild anemia, or normal? Because that's where the therapeutic thresholds are. So this device, just as of this year, 2021 actually, has been launched by Bosch in India, and now they intend to launch it in several African markets. So hopefully comes full circle. It got an award or two, but we don't know. The jury is still out on whether or not this will eventually be marketed as a low-cost device such that community health workers can use it, but that's our hope. We work with kind of some advocacy on the demand creation side, so that hopefully might happen. But it was a journey where, we really needed to solve the hard technical problem first. And several of the stakeholders, several of our friends, partners kind of dropped off along the way because they said, well, come back to us when you're ready. And then learn carefully from the needs of the payer policymaker, and not just while you design with the end user in mind. In this case, the telemedicine component became a big deal for governments wanting to use it. Switching on, I got lots of little stories like this to share. It might sound like a deluge. So task shifting. What you heard in the previous story is really this concept of task shifting, which is becoming a mainstay of global public health interventions, where tasks that were done previously by highly skilled practitioners are being shifted to lesser skilled providers. So something that was done by an obstetrician being done by a midwife, something that was done by a neonatologist being now done by a community health worker. Very limited in scope, but that is what is allowing some of these life-saving interventions to be taken to the rural communities. So another example of task shifting, where we really try to push these boundaries of task. We move to this issue of neonatal mortality, right? About 3 million neonatal deaths occur each year, and 75% of this happens within the first 7 days of life. The common causes, if you survive birth asphyxia, common causes are sepsis, pneumonia, tetanus, diarrhea, overall clubbed together as neonatal illness. And the problem is that these signs, the early signs of this neonatal illness, are actually pretty well defined. WHO actually came up with the 7 signs, the IMNCI 7 signs. Difficulty breastfeeding, convulsions, chest indrawing, movement only when stimulated. These are kind of the qualitative signs that a mother would know. And then quantitative signs, like, is the respiratory rate above 60 breaths per minute? Is the temperature hypothermic or hyperthermic, which are qualitative objective signs. Now, the challenge is that if only these signs could be assessed during the first 7 days of life, a couple of times a day, even once a day, most of this unnecessary burden of neonatal mortality could be completely avoided. Because now what happens is the mothers bring their neonates to the district hospital when it's too late. Like, antibiotics could have worked, intravenous antibiotics could have worked. Maybe a little bit of admission to the ICU could have worked, but it's too late. So governments recognize this. They have these community health workers who are actually in Uganda, for example, where we worked on this project. Community health workers are tasked with this well baby visits. They're supposed to visit on day 0 at the home of the mother, and day 3 and day 6, and check up on these 7 IMNCI signs. But what happens in reality is that because of governance and them being busy and not understanding the importance, this seldom happens, honestly. Even a single visit is optimistic. So what we proposed is, what if the most motivated person, the most invested person in this equation is the mother who is with their neonate? What if this mother could somehow be empowered to screen for these 7 danger signs multiple times a day, and then that trigger a care-seeking behavior? Wouldn't that be lovely, right? So fast forward, our team actually developed, we were one of the Gates Foundation Grand Challenges awardees, got a little grant, and then they developed iteratively this low-cost sensor band, which measured the quantitative danger signs, the temperature and the respiratory rate, and connected to a smartphone, which the business model was that this would be a rental model, and we did willingness to pay analysis. So, every community health worker could have one, and then it would break even if they rented it out during the first 7 days of life, and blah blah blah. So we worked out all this nice business model. But the smartphone would then guide the mother on how to place this band. It would nag the mother to do this once or twice a day. It would also guide them through the qualitative danger signs through nice GIF animations, and they would click yes or no. And if something was remiss, then it would trigger an alarm to trigger care-seeking behavior. We actually, our students, myself, we interviewed about 130 mothers iteratively, demonstrated various iterations of prototypes, worked with about 160 community health workers, 120 key opinion leaders in the country, and really positive feedback, really strong positive feedback. And this was done rigorously as well. Actually, a usability study, if any of you are interested in details of usability study, this is recently published in JMIR, and we tried out different versions of the app. We looked at people with no previous smartphone experience versus people with smartphone experience. How correctly were they able to respond to the qualitative danger signs, et cetera, the willingness to pay in Ugandan shillings, all of that. But bottom line is that this was actually quite usable. We also did an acceptability study where we recruited mothers on the day of birth at the Iganga District Hospital, and this device was given to them. The community health worker would train the mothers, and the device would follow the mothers to their homes, and the mothers would then have to remember their training and screen their neonates using this a couple of times a day for the first 7 days of life. And this was a very small, pilot study. 20 neonates were recruited, 18 here, but because 2 dropped off. But 20 neonates were recruited, and the mothers autonomously used it. And our team would follow the statistics of what was happening. This is also published, the acceptability study. Very well accepted. But what was very heartening, these are all grad students, like first-year grad students, fresh out of the undergrad. It turns out that two babies were referred to the Iganga District Hospital as a result of this device. And the protocol was that the mother would contact the local community health worker would recheck, and then if she decided, she would bring the baby back to the district hospital along with the mother. And the neonatologist, the pediatrician there, looked at the child and said, yeah, the baby is developing signs of sepsis. We're glad you brought them in time. And the mother and the CHW had absolutely no idea anything was wrong with the child, other than the fact that this device was yelling like crazy at them. So this was very heartening for engineering students to have developed something, and and for them to feel that maybe we made a difference in the lives of these 2 babies. Of course, this is a very small sample size. Those of you know anything about clinical trial design, that this is not statistically significant, but this is just a very preliminary evidence that supports that this is acceptable, this is usable. The reason I'm telling this story is that it's not just enough to just develop a technology and show it to some users and feel good about it. If you're serious about it, you have to figure out a pathway to keep on slowly but steadily generating the evidence. And at some point, you have to do a randomized control trial, you have to do a clinical trial. But even before that, way before that, there are baby steps you can take. And these are some of the baby steps that we just showed. Yeah. Well, that's the good part of the story, but it turns out the smartphone really was not the smartest of the ideas. The rental model that we talked about, it's great, but what if we could eliminate that? So currently, one of the teams last year worked on, what if we could eliminate the smartphone and come up with a low-cost audiobook that kind of does the same thing that the smartphone was doing, except it'll be like those flip audiobooks, and it'll talk to you, and it'll have some low-cost electronics that will do effectively the respiratory rate and this thing. So this is that, but at the same time, some of the lessons learned from this were like, identify your biggest project risks, unknown assumptions. First, in this project, we had to continuously learn from stakeholders, lots of co-creation. Interest of time, I could not tell all those different iterations that came in between. And don't fall in love with your technology. Like, be married to the problem that you're trying to solve, not how you attempted it. I tell my students, the first idea you have, even the first technological prototype that you built, you probably should just throw it in the trash. Just learn from it and then start all over again. So your first idea usually is not your best idea. And then in this project, as good as it sounds, the team ran out of funding, like the Gates Foundation funding ran out. And so then they're scratching their heads. What do we do when the dollars run out? And that's a reality for a lot of, startups as well as academic projects. So, and I don't actually have an answer for that. So moving on to the next one, a very interesting, another project we're particularly proud of. This is about, so I'm moving all over the place from maternal anemia to neonatal sepsis to now cervical precancer. This is also a big killer of, women in sub-Saharan Africa, particularly. Some of you might have heard of the pap smear, right? Which cervical cancer has a slow growing precancerous stage. And that offers an opportunity to be detected by a routine annual pap smear after a certain age in women, and therefore, and then a complete cure. So, but the problem is that in low resource settings, pap smear is not feasible to do routinely. So governments and WHO, others have instituted something known as a single visit approach, where instead of the pap smear, you have something called, acetic acid or vinegar. So a midwife can actually wash with vinegar the cervix of the client, and under direct visualization, any precancerous lesions show up as white patches. It turns out it's actually reasonably accurate, almost as accurate as the pap smear. And since the result is instantaneously available, the clients are then offered treatment. And the treatment is cryoablation, which is a safe and effective treatment for cervical precancer. Midwives can do it safely. You don't have to excise anything, you don't have to biopsy anything. Turns out, for medical legal reasons, cryoablation is no longer the treatment of choice in the West. In the West, like if you are a woman in United States and you get detected with cervical precancer, you won't be cryoablated, it'll be an excision biopsy and you'll be cured, right? That's not the issue, but you need to document what happened for medical legal reasons. So cryoablation kind of fell out of favor for those reasons, not because of efficacy reasons, because of those reasons it fell out of favor. What that means is that the people who used to make this cryoablation equipment, two companies, I think, out of somewhere in the Midwest here in US, they don't want to make it anymore. It's not profitable. So it's like a technology that's 30, 40 years old. It's like using the abacus if these were computers, right? So this is an example of the wireless surgical gun. It's a complicated piece of, pipe ending in a cryo gun using adiabatic expansion of gases. It cools the tip, and the midwife applies this to the cervix, and there's a cool thaw cycle. Many custom parts. The cryo gun is $2,000 to $4,000. It breaks every time. There is no medical grade nitrous oxide available. People source carbon dioxide because there's a Coca-Cola or Pepsi plant everywhere in Africa. So they get this non-medical grade liquid carbon dioxide to use it, further breaks the equipment. So the innovation challenge was, could you design something that actually helps us scale these cervical cancer camps? And we don't have enough nitrous oxide, and something that works with the liquid carbon dioxide that we have. So the teams actually went through a lot of ideas, Peltier devices to car batteries, cooling down something, everything. But what they came up with is a very elegant, simple solution, which they call the cryopop, a popsicle made of solid dry ice. So it turns out if you expand liquid carbon dioxide in a closed chamber, a part of it sublimates to solid carbon dioxide, known as dry ice. That's how, this is known as a snow horn. This is how ice cream factories actually make the dry ice. So they made a single injection mold, made of nylon, simple tool, which looks like the gun that the midwives are used to and trained on. It looks like the cryo gun. The handle is similar, except no complicated tubes, no nothing. You just open this adapter, and within 30 seconds, you get this popsicle made of dry ice. You apply the cap, and it turns out the freeze profile of this thing, and students tested this on various, on a goat model, it's actually better than the Wallace surgical gun. And this costs about $30 to $50 to manufacture, as opposed to the $3,000 price point. But the best part we discovered later on, after some experimentation, is that this method of cooling is about 15 to 20 times more energy efficient than cooling based on adiabatic expansion of gases. What that means is that the same $400 carbon dioxide tank that could previously treat only 20 women can now treat 400 women or 300 women. The cost per woman just went down like an order of magnitude. And furthermore, this massive 50-pound tank of gas had to be lugged on, massive vehicles, because you typically expect 10 to 15 patients in a cervical cancer camp to be treated. But now you can have a midwife in a backpack model. They can carry small 2-pound or 4-pound tanks of carbon dioxide and still treat those 10, 15 patients with just 2 pounds of carbon dioxide. So this was a massive, was really proud of this innovation. Our students said, and it's multiple years of work. This obviously, this story is not in a year, but by the end of year one, they kind of get to this proof of principle that, we can, using this method, we can freeze goat services. And then subsequently, of course, we raised money from NIH. There's a human cancer trial. It's ongoing in Philippines and India right now. About 1,000 patients have been treated on this already for cervical precancer, CryoPop. And this company, Pregna, turns out, even before a trial has ended, they just so liked it. They have licensed it. And this is the device embodiment that is now in the market, and it's been launched in India and in 13 other African countries. And this is, you can look up Pregna, the CryoPop device, and this is now going to actually treat patients with cervical cancer and hopefully let African countries scale up their cervical cancer seek and treat programs. So that's another example of a type of project that was done here. There's 2 more stories. I want to leave time for questions, but maybe I can rush through. There's like 2 other very interesting stories I want to go through before I pause. Switching gears completely, telemedicine. Here's an example. Some of you might have heard of the lean startup approach, which is a very different approach to product development. So we tried this lean startup approach in developing this telemedicine company. So switching gears from cervical cancer completely. And we always say, right, like, ask your users, ask your stakeholders, what do they want? Show them your prototypes. But that sometimes might also not work too well. You actually have to, test your usability and acceptability hypothesis in somewhat different ways. So this is the story of a startup. This is now a startup, and disclosure statement, I'm one of the co-founders. It's a nonprofit. I am one of the co-founders. So the question we asked back in the day is, could telemedicine bridge the access gap? In rural parts of low and middle income countries, there are very few doctors, almost close to statistically zero. They all reside and practice in big cities. And therefore, there's this huge access gap. And when rural patients in need of their primary healthcare needs have to go to a subsidiary health center or a primary health center, which might be within some radius, those are not adequately staffed, infrastructure. And if they have to go to the city, that's a huge opportunity cost. And usually they put off seeking care till they can avoid their symptoms no more. So back in the day, we thought, could telemedicine do this? And we were obviously not the first people to think about the term telemedicine. But it turns out in most telemedicine models that we saw in low and middle income countries, there would be like some high bandwidth VSAT network, and a doctor, some big shot doctor in the city would get on video call with this rural patients, and the community health worker there would just be a glorified telecommunications operator. What our students did with this is that they developed, or they hypothesized that what if we could develop, an AI or expert system-based platform that somewhat mimics the intelligence of a doctor's mode of eliciting your signs and symptoms. When a doctor asks you questions, right? If you're a 65-year-old man with chest pain, when you come into the doctor has a set of hypotheses in his or her mind, versus if you're an 11-year-old girl with chest pain, a very different set of hypotheses. Maybe coronary artery disease here, and maybe doesn't want to do homework here, right? So the next question you ask is very different, colored by your knowledge of medicine, pathophysiology, experience. A community health worker can't obviously do that short of extensive training, but could you put that in an expert system? Could you put that in an expert system that autonomously allows them in a task shifted way to do a lot of things such that the doctor's time is saved and a low bandwidth connection could dispense off like a very high yield telecommunication consultation? So the question was, well, building this expert system is not going to be easy. Right? That's not trivial. That's going to be some serious technical work by a bunch of docs and software programmers, maybe at Hopkins, maybe leading docs in India. But what if you built all this expert system and then you realized, this actually is not going to fly. Not because you can't build an expert system, but because, patients don't see value in, being seen this way, right? Like, will patients see value in accessing care in this way? Can a community health worker use this method, right, to gather patient data with sufficient competence and confidence? Furthermore, will doctors on the cloud trust the findings of a community health worker enough to be able to arrive at a management plan? Like, can you recruit and retain such cloud doctors? We felt those are actually bigger project risks. The expert system, I know it's very resource intensive. It needs a lot of expertise to build, but it can be done. But these questions, if not answered upfront, you're screwed if you spend 3 years of your life building this and then nobody wants to use it. So how do we do it? So Wizard of Oz, right? Anybody remember Wizard of Oz, right? Finally, it was not a computer, it was a person, right? Pretending to be the computer. So the lean startup approach, if some of you have read the book, and I would really recommend for, frugal innovators to read the Lean Startup. Like, could we answer these questions in a lazy way? And here's literally what I did. We made a fake telemedicine expert system. And the fake expert system was a bunch of real doctors, myself included, speaking to a community health worker on a headset within earshot of the patient community health worker interaction. So if a patient says, this is my complaint, I would tell the CHW in their ear, ask this next. And then based on the patient's response, I would tell the CHW in their ear on a Bluetooth headset from a distance, so the patient doesn't know I'm doing that. And this real doctor is the pretend expert system that would then take 3 years to develop if the rest of the things panned out. And then the CHW would actually write down those findings on a sheet of paper. And then me or one of my students, we would take that sheet of paper and run over. We were the internet. We ran over that sheet of paper to the next house where some of the senior doctors we had brought in from the city were sitting with a headset. And I said, well, pretend like this patient note ends up on your computer screen. Right now, pretend like this is a computer screen. Read it, have your initial hypothesis about what this patient might have. And now talk to the patient on the phone. And then from the adjacent hut, they would call the patient on the phone, and then there'll be a telemedicine consultation. And we observed and learned so much from this interaction. We did this for 14 days. Some of my students, actually, my co-founder, Neha, my PhD student who just graduated, she actually lived with community health workers in their houses for about 2 months. She lived with them for 2 months, understanding like what is it that drives them, what are their pain points, what are their challenges. And so we learned so much about like what patients value, what are the things that the doctors would like to see more in order to be confident in arriving at a management plan. How can we recruit and retain cloud doctors? What are some of the kind of failure modes for the community health workers? And this model just co-created, iterated so many times. And fast forward, we now have this expert system called IU, which has about 367 common symptoms, 143 physical exams. This has been published every which way. Neha did her PhD on this, a lot of public health assessment. And this is, as I said, this is spun out as a nonprofit, IntelliHealth. And IntelliHealth now actually is a fairly successful nonprofit. We have about 70 employees in Mumbai and 2 million plus in revenue, and is now served over 100,000 patients in various, some of the most rural, remote parts of India, tribal villages in India, as well as in Philippines. We got an award from Grand Challenges Canada to deliver telemedicine in humanitarian crisis affected population in Syrian refugee camps. And we're the national telemedicine provider in the country of Kyrgyzstan, of all places. There was a UNICEF related project. But anyway, this is a story of a student-driven project where we did not do what engineers would instinctively do first, which is solve the technical problem first, build the prototype first. Because in this case, we realized that the biggest project risks were not in solving the technical problem first. The bigger project risks were human behavior related, human psychology related. And if we could answer those first in a lazy way, in a Wizard of Oz way, then we can have much more confidence to invest our lives and our time in solving the hard technical problem. So this is quite the opposite of the very first example, the hemoglobinometer, where, if you solve the technical problem first, that's what you got to do well, right? Of course, people will use it if you can solve it. So there's no one size fits all. It's about project risk. You as the innovator have to think about where are your bigger buckets of project risks and solve that problem first. And so these are some of the programs, and check it out. It's a great kind of inspirational story, especially my student Neha. She finished her PhD and built this company while doing her PhD. And so that's the type of work. By the way, again, plug for CBID. If any of you undergrads want to do grad school doing this type of cool stuff, think about us, all right? And my last story for today, I hope there's some time for questions. Mosquitoes is about mosquitoes, not maternal neonatal health. So this is a story that takes us from Brazil to Virginia to Africa. Mosquitoes, it turns out, are the world's deadliest animals. Not lions, not tigers, not hippos, not snakes. It's mosquitoes. Yeah, by the way, anybody want to guess what's the world's second deadliest animal? It's actually humans. Turns out humans are the first. Wars, homicides, all of that, about 500,000 there, whereas mosquitoes is close to 1 million deaths per year attributed to mosquitoes. Anyway, coming back to the story. Part of mosquitoes carry a lot of diseases, right? All of you kind of know this: malaria, dengue, Zika, chikungunya, yellow fever. And part of mosquito control strategies is the knowledge of mosquito species spatial distribution, because different species carry different diseases. Even within a genus, such as Aedes albopictus versus Aedes aegypti, both can carry dengue, Zika, but the breeding grounds are very different. So knowing which is the dominant species in this area will guide intervention strategies, right? So in order to get this information, almost every municipal district across the world where mosquitoes exist use something called vector surveillance. They would typically place traps, which are kind of devices that fool mosquitoes into coming in thinking there's a warm-blooded meal or there's a nice place to lay eggs, but they're designed in a way that they come in, it's like Hotel California. You can check out anytime, but you can never leave, right? So once they come in, they stay there, they die, and the health workers visit again 7 days later, and they empty the trap, and they get a count, okay, I have these many this species, these many that species. Except it turns out it's pretty darn hard to identify the mosquitoes. You have like really qualified PhD entomologists, masters in entomology people, one maybe in a district, if you're lucky, in Africa, with a microscope, peering on it all day, reading the trap catches that have been brought to them from all over the district. So needless to say, that data has a huge time lag, it's not spatially dense enough, et cetera, et cetera. So fast forward, what we designed at the height of, we were one of the Zika Grand Challenges awardees. We got like a good chunk of change, $1 million from USAID. And with that type of chunk of change, you can pretty much design what they tell you to design. And we designed a smart trap. We designed a smart Aedes aegypti trap that had a little cell phone, like a camera built into it with some AI algorithm that we developed, which would automatically count and speciate the mosquitoes and report it to a central dashboard. So voila, smart concept, right? No more health workers need to go out every day. You can do this, distributed grid, and you can get a Google map of mosquito species distribution and therefore deploy your interventions accordingly. Fantastic. So the trap, this has been published. If you're interested, you can look at the trap design. We went through lots of hoops on the optics. It was hard engineering. It wasn't trivial engineering. Some good rigorous engineering had to be done. And, we met with several provincial governments in Brazil. They loved it. But what we realized that we had actually created something far more valuable than the automated trap. We had actually created the world's first deep learning algorithm that could automatically speciate mosquito species and could also tell whether if there was a novel species being shown to it that it had not learned previously. It would tell you that I don't know. And that's actually a hard deep learning problem. That's actually a hard machine learning problem. And this is published recently in scientific reports. You can look at the algorithm. So it can, and we built one of the world's largest databases, about 15,000 mosquito images, identify about 39 species, far better than any known entomologist on planet Earth. So with about 99% accuracy. It was against a gold standard DNA kind of PCR tagging of the species. So it actually did far better. Our donors, our partners, suddenly saw that we are also doing very well on Anopheles mosquitoes. In Brazil, our focus was on Aedes because Zika. They said, well, the bigger burden of disease is actually in Africa, in malaria. Could you guys not do this for malaria too? And then, by the way, we don't care much about that trap. We were just being nice to you. We don't care much about that trap. What we really care about is this algorithm. Could you not put this in a smartphone app or something so that my community health workers could now perform like entomologists? And we said, wow, why didn't we think about that first? Whatever happened to the lean startup approach that I just waxed eloquent about previously? So we had to drop this idea of the smart trap, but we had this gem of an algorithm. So fast forward now, this has pivoted, a complete pivot to a new product called VectorCam, which is a low-cost portable field tool for rapid morphological identification of mosquito species. This is my new batch of students. This is in Ghana at the President's Malaria Initiative Office, PMI VectorLink offices. And here's the device. It's a smartphone with a little macro lens, clip-on lens, and a little light box that provides uniform illumination. And you place a mosquito specimen under the light box, and here's a cartoon of this thing. And if you like, you take the image. If you like it, it'll then display. It'll run the algorithm and display what the species is. This is kind of some of the master students from across this thing. We have about 30 prototypes. It continues to iterate. Ghana, Uganda, this is where the team was. Actually, they are flying to Zambia right now as I speak. I kid you not. I mean, 5 of my students are going to Zambia, and then subsequently they'll come to Uganda. They're carrying with them today a new batch of prototypes for a usability study. I was supposed to be there, but for certain reasons I couldn't, which is why I'm giving this talk today. But they're doing their third kind of iteration of their usability study, and conducted a lot of feedback with stakeholders, including at the Ministry of Health. So we engage with the ministries very early on, so that you understand, because they are such an important stakeholder. It's not just the community and not just the health workers. They are very important, but to engage with the ministry. And in Uganda, they really want to move malaria vector surveillance away from sentinel sites, which is all that they do right now, which is 1 or 2 sites in the country that extrapolates like the data for the entire country, which is a terrible way to do vector surveillance, because mosquitoes species can vary like by locality to locality. So they would like to move to community-based surveillance, and Uganda is just about to start a massive vector surveillance drive in 54 districts in Uganda of their 137, and they've invited us to be part of that with this technology. And here's a snapshot of, it's not one size fits all. There was a lot of co-creation that was done, like different embodiments of this device. Simple, like they kept telling us, we collect our mosquitoes in a petri dish. Could you do this that's compatible with a petri dish? It'll make it faster. Could you do it as a video? Could you do a conveyor belt? What if, it's more of a telephoto lens as opposed to a macro lens? So in the interest of time, I can't go through all of this, but, a video mode, like you hover the cell phone with the macro lens and kind of just tells you which mosquito is what, and allows the community health worker to rapidly sort through it. So we went through all of these, and there's ongoing studies going on, but the overall goal is that we can task shift and democratize vector surveillance and hopefully make a big impact on the malaria epidemic. Again, expensive lesson for us here is, do not fall in love with your original idea. Be open to radical pivots. We spent $1 million developing that smart trap. And what did we get for it? We got an algorithm. Thankfully, we're pivoting that to a lower cost tool. That trap would have been like a $50 or $100 trap. It's not going to be useful in Africa for malaria. So this low cost handheld tool is really what's useful. So it's a pivot. It's a pretty radical pivot, but it takes the learnings from this first iteration and it forces it into a completely different product embodiment, which is what now a lot of international donors and our supporters, NGO partners, they're looking forward to us getting our act all together, as in this is still preliminary, needs to be an industrialized device so that it can be introduced into country programs. So I will pause there. I have one more story of a partogram, but I kind of want to skip that, and the slides will be there. You can read through it. But this one, the long and short of this was a tool we developed based on WHO guidance, an electronic version of our labor and delivery management tool. After 8 years of work and several publications later, WHO changed its guidelines just last year. So all of this work really has to change because this whole hypothesis no longer holds true. So that's the teaser. If you want, you can read this. But even as an innovator, your evidence-based guidelines might change. You might, as an engineer, you might design something based on certain medical guidelines, and those might radically change. So the guidelines for management of labor and delivery, WHO's guidelines for midwifery-based management has just changed as of 2020. So all of this work, 8 years worth of work, has to also be modified. In the interest of time, I mean, I'm way over, but the one thing, if it sticks with you, is that innovation is always iterative, grounded in close contact with all stakeholders. And that's the way you increase your probability that you're solving the right problem and solving it the right way. All right. So with that, thank you. And questions now and offline and email. Yep. Thanks.
Thank you so much. That was very diverse ideas, and interesting to see that it's not only one size fits all, but really there are many ways to solve a problem. And I guess you're limited by your imagination. So I wanted to just start off with a couple of questions. From a program perspective, how did you manage to sort of build all these partnerships so that your students can travel to these places and live with community health workers or have in-depth conversations in a way that doesn't, I suppose, infringe on people's time or other things? Because sometimes there's an opportunity cost, right, in trying to engage with individuals that are already strapped for time, or they have other obligations. So I guess this two-part question. One is, how did you cultivate the partnerships? And the second is, how do you engage people when there are so many other things happening in their lives?
Yeah. So we realized early on that if we thought of ourselves as like an educational program where we're going to to this partner site just to learn and then say our goodbyes, be nice about it, but say our goodbyes, then this feeling of this is an imposition on our time becomes amplified. However, if we kind of pick some partners, start small, be respectful of their time, and then build upon that, and then we pay close attention to what's in it for them, right? A lot of these partners actually want solutions to these problems. The partners could be so for this malaria one, for example, we are in partnership with the National Malaria Control Division in Uganda. They give us the time of the day. The head of the NMCD serves on the graduate committee for my students. This is a super busy person. No minister serves on a graduate committee of like a bunch of grad students, no matter where you go to, doesn't matter, right? Duke, Hopkins, Stanford, wherever you go to, no minister makes that time. They are making it because they see value in, if this pans out, and they know that their feedback and nudging can help shape it in the way where it will add value for the country. For community health workers, similarly, for small community programs, and then for NGOs like JPIGO, which is a large NGO in the maternal neonatal health space, a Hopkins affiliate that we work closely with, we would make sure that we as faculty and kind of the leadership in the center and train our students similarly, that pay close attention to what their needs are. And we now do projects multi-year. So some success stories breeds others wanting to stick and work with us. So we're trying to build depth in those partnerships. Initially, it was imposition on time, obligation, but when you get your foot in the door, you kind of demonstrate some value, have some success stories, some joint learning, and people make time. When people see value, when people are excited about something, they have made time. That's how every single one of these examples that I talked about was not a cold partnership, but partnerships that we had built like carefully over a few years of just being sure that we're going back to them with our solutions, learning from them, and they see that we're respectfully engaging with them, and we're in it for the long haul. We're not just a bunch of tourists coming in to just learn some and then say our goodbyes. Yeah.
Thank you. Along the same lines, I have a follow-up, which is the importance of task shifting, right? You have the technology, but someone has to deliver care. I'm sure you've been asked this question before, and we're facing that in many settings where there's a reluctance for people who are trained, professionals who are trained for a long time to do a procedure, to then shift that to a community health provider. So, you talked about what's in it for them, what's the value, right? So clearly the value proposition is important and it can be different for different stakeholders. So how do you convince them, or what are the challenges in trying to convince them that this is better for the patient, even though it might not be better for, their revenue or their earnings?
Well, sometimes it actually might be better for the revenue. So that's one strategy, like in the telemedicine case, for example, right? Some of our